Fred, would you like to? Hi, Fred. Today is our last MOOC Vaccinology Hangout. We combined the week 5 and week 6 together because we have some schedule conflicts. So would you like to welcome everybody and say something about our last MOOC Vaccinology Hangout?
Yes. So welcome everybody who's looking to this session of Hangout. In fact, we had some problem last week, so we couldn't manage to have the last session. So we mix the two sessions in one, just like say GB. So today will be dedicated to the last part of this course, and I hope that you've been able to follow efficiently every part of the course, every session. So in the session today, I will first answer some questions related to the price of vaccine production, maybe a question also on RSV disease and RSV vaccine and enhancing disease. Then we will welcome Maria Elena Bottazzi, who will answer your questions about vaccines against parasitic diseases. So also I would like to say a few words about the vaccine exams and the different vaccine tests that you have on the MOOC. Please continue to ask questions on the discussion forum if you have problems to answer these questions, because we are able to help you and to give you all the information you need. So let's go. Please, let's start to the questions relating to the cost of vaccine production.
Okay. Yes, we have the question on how to determine the cost of vaccine, and what would be the determining factor to say how much the vaccine will cost, and how can we make that as low as possible, since if we want to distribute it in a poor country, how can we go about that?
Okay, so first of all, the cost of a vaccine, let's say the cost that the consumer will have to pay, depends on different things. First, all the research and development costs for the vaccine. This has to be reimbursed to the company who made this research and this development. Second, the cost of goods to manufacture the vaccine, also to give back to the manufacturer, and the cost of distributing and delivering the vaccine. Then, lastly, the benefits of the company who sells the vaccine. So how to calculate all that and to at the end up in a rational price that is affordable according to the country where the vaccine is distributed. That depends, of course, on the vaccine. That depends on the difficulty to develop the vaccine. If the research and development took 3 years as compared to 20 years, of course, the price will be, the cost and the price will be different. That also refers to the technology used for the vaccine. And obviously, live attenuated vaccines are affordable, and more developed, more complicated vaccines are more expensive. Let's say, let's talk of a live vaccine. So live vaccine, you just grow the virus. So except that you need to have a facility which is completely fully sterile, the vaccine grows by itself, and you just collect the virus and you dilute the virus. So at the end, the price is not too low. On the contrary, if you make a VLP vaccine, you have to prepare the VLP, you have to set up the fermentation system to grow the VLP, but you have to collect and to purify the VLP from the medium. And this is difficult process, so expensive process that also should be sterile all along the process. And you will concentrate in that case the vaccine. So from a big volume, you will make a small amount of doses. And on the contrary, with a live vaccine from a big volume, you will make a bigger number of doses. So all these have implication on the price of the vaccine at the end. Then for distribution, that depends on the type of vaccine that you distribute, whether it's a vaccine that is part of the EPI, Expanded Program Immunization, and in that case, the delivery and the cost for the vaccination is taken in charge by different organizations such as UNICEF, Gavi, and the WHO and the country itself, the Ministry of Health of your country. If you are in a country where there is a health system that reimburses the vaccine, the price of the vaccine will be reimbursed by the health system. So the price of the vaccine will be negotiated before between the company and between the health system. So there is many different cases to discuss how the price and the cost of a vaccine is defined.
Okay, thank you. And for the next question, we have some question about the RSV vaccine. As for the RSV vaccine, as the maternal antibodies can interfere with the infant vaccination, how can we go about infant immunization for the RSV vaccine?
Okay, so concerning the RSV, the story of the history of this enhancement has been observed in the 60s, in 1962, when using a formalin inactivated vaccine that was based on a live virus, RSV virus, respiratory syncytial virus, that was inactivated by incubation with formalin. And this vaccine was used in a small cohort of children, and it was rapidly observed that babies that had been vaccinated with this inactivated vaccine had a more severe disease when the epidemics was there, and therefore the vaccine was immediately stopped and taken out of the market. Then years after, researchers have been looking for the reason why of this phenomenon. Then it was found that antibody may enhance disease. If you elicit antibodies that are not efficient to neutralize the infection, that may be either neutralizing antibodies that really neutralize the virus, or antibodies that are able to, through ADCC, for example, antibody-dependent cellular toxicity, may induce a killing of the cells that are infected. These are antibodies that are effective, that have effective activity. These antibodies are efficient, but the antibodies who do not have these activities are not efficient. And in the contrary, they can be deleterious, meaning that they can bind to the other extremity, to their other extremity. They can bind to Fc gamma receptors on a number of cells, such as macrophages, monocytes, or many other cells. And through this phenomenon, and at least this has been shown in vitro, in vitro experiments, these antibodies are able to enhance the infection of these cells, because they take the virus and they put the virus inside the cells by an additive mechanism next to the normal mechanism through the receptor, the viral receptor. So this has been shown using this inactivated vaccine with RSV. The phenomenon is also known for dengue disease, in natural dengue disease, meaning that if you have antibodies to dengue that are not neutralizing, you can enhance the disease when you are infected with another serotype. Let's say you have antibodies to dengue 1, and then you are infected by serotype 3 a year or two after, or even 4 years after. Then the antibodies to dengue 1 are not able to neutralize dengue 2 or dengue 3, but are able to increase the infection by this serotype. So in RSV, the enhancement was demonstrated with this experience of this inactivated vaccine. And the question was, is this phenomenon also observed in the natural disease, meaning are the maternal antibodies that the mother transmit to their babies, should these antibodies be responsible for enhancing the disease and for special severe disease in some babies? This is not known, in fact, and I have looked to the literature in that field, and I didn't find any paper describing that. So this is a new subject for research, but this might be possible, because I think that there is no relationship between the level of maternal antibodies transmitted to the baby and the occurrence of severe disease, severe RSV disease in babies.
Okay.
So one opportunity should be to vaccinate the mothers, to immunize the mothers. And this was also a third question on that RSV field.
Yes.
That was, is it possible to vaccinate the mothers? Yes, it is possible. And there are vaccines, and specifically one vaccine, which is already in phase 2 or phase 3, I think, of efficacy testing in pregnant women, that consists in vaccinating the mothers, then hoping that after delivery, the mother will transmit during the pregnancy, and after delivery, the mother will transmit the antibody to the babies, and that this antibody will be able to protect from disease.
Okay.
The result of a phase 3 experiment up to the baby that are born, I think, is not finished. And of course, that will be the definite result on this type of test, to see whether babies born from mother vaccinated will be much more protected than other babies.
Okay. Okay. So we'll probably have to wait for phase 3.
Wait a year or two for this result, exact.
Okay.
And in that case, also, it might be possible to boost the baby after birth. Let's say waiting 6 months for the waning of mother's antibody, and to boost the baby by another vaccine, a baby vaccine against RSV, to give them a strong level of antibodies for the next years.
Okay, great. That's for the RSV vaccine question. We have a vaccine against the worm or neglected diseases. I noticed particularly for Dr. Botassi, but she will join us a bit later on. Maybe you have some insights on this question. For developing the vaccine against neglected diseases or the worms, would it be better? These are the questions from the discussion board. He said that would it be better to promote the environmental health than just spend years and money to invent vaccine?
Yeah, of course, it's a good question. And it's always the debate when we talk of vaccine against parasites, worms, or this kind of disease that are really specific of poor countries. Of course, we can discuss this aspect, and we could say let's improve cleaning water distribution, electricity management, and cleaning of streets, and hygiene in the poor countries, and we will get rid of this disease of poverty. This is true, but these economical development are very expensive, and in most cases much more expensive than developing a vaccine. So I believe that in a first approach, when these countries are not yet developed as much as they can have clean water in every house, clean evacuation of water, clean health system, and good hygiene, I think it's worth to develop new vaccines, because at the end the vaccine is not so expensive, and distributing a vaccine against helminths or worms, if they have the chance to protect the babies against this disease, will not be so difficult. I think that it should be much more difficult to give clean water in all African cities and villages than giving a vaccine for the moment. It will take years and years and decades to fully develop Africa, and it may take just 1 decade to develop a vaccine.
And she's joining us. Hi.
How are you?
Hi.
Hi, Maria Elena. How are you doing?
Very good, thank you. How's everything over in Paris?
Yeah, good. Good weather this afternoon.
Oh, that's nice. We finally have 1 day of break from the rain, but it's been quite awful here in the Houston area. Lots of flooding.
Oh, really?
Yeah, yeah.
Oh.
Okay.
We have a question for you.
Yeah, we were just discussing about the vaccine against worm, because we have a question that would it be better to promote the environmental, make it everything cleaner than developing a vaccine? And yeah, maybe I'll let you start with that.
Sure. Well, I mean, absolutely. I think one of the things that, it was pretty much stressed during the presentation is that, there is no one single intervention that most likely would be able to take charge of, dealing with these types of neglected diseases. So it has to be an integrated approach. So by no means we are ever advocating for just a vaccine alone. Like, we don't also believe, for example, just drug administration alone will most likely do it. In fact, if you look historically, how many years and years have we been trying to not only, of course, improve health, sanitation, water access, education, but alone with no other interventions, it's not going to really ever happen. So we can't rely on just saying we should stop looking for novel, new tools just because, we only want to advance one area of, of control. So, vaccines should complement, the other areas, right? We should complement the dissemination of the information, the advocacy, the, education, certainly access to clean water, access to, better infrastructure, access to, of course, toilets, and also, of course, if there are drugs available, that in certain cases for some diseases, drugs may work better than others, but we need to continuously look for better diagnostics, better, preventive tools, better therapeutic tools.
Okay. So is this vaccination against worm has the lifelong protection, or why this has a more benefit over just mass deworming?
Mm-hmm. So I think that if you look historically, of course, the thought of vaccines have primarily always, relied on that thought that, vaccines should provide sterilizing immunity. So what you're saying, right? You get vaccinated once, then maybe you get a booster every so often, but, you're protected for life. That may work really well for some of the most, let's call them, viral or even some of the bacterial diseases. But remember, worms and even other protozoas, like you can even see with malaria, it's probably going to be very unlikely that, a vaccine, a standalone vaccine, will provide full 100%, sterilizing protection. So we believe that these vaccines will, provide most likely an immunological, profile in the population that will allow to certainly reduce the burden of disease, right? So what we're really looking is maybe not necessarily prevent, the infection, but what we want is to, even though you have infection, that you reduce the burden of the disease that the infection causes. So therefore, bringing it down where you can actually not suffer from the disease, right? So in the case of hookworm, one of the things that we're advocating is, drugs certainly cure, but don't prevent reinfection. A vaccine could, even though may not necessarily 100% prevent infection, may prevent very high intensities infection and therefore reduce the burden of disease. And the combination of both would eventually, hopefully, could be 5 years, 10 years, 15 years, slowly interrupt the transmission of the disease. Because as you reduce the intensities, you have less infective material that is potentially going to reinfect other people. If you're still adding the drug, you may complement that some people get cured, and therefore, you see what I'm saying? So it has to be a balance, right?
Okay. Okay. Thank you. And another, probably our last question: what are the vaccine for the neglected diseases that currently in the clinical trial, and the one that considering that passing the valley of death?
So, and it's funny because I know who the person who put the question, and I'm gonna go talk to him because he works with me next door.
Oh.
So that's good.
I'm sorry.
So I think the trickiness of the question is that it's currently in clinical trials, and right now, from the list that I had provided, only schistosomiasis is in the clinic, and only hookworm is in the clinic. So, there are maybe other vaccines that, I don't remember what were the list, so we don't have, certainly Ascaris and Tricuris, there are no candidates that are in the clinic, which are the other soil-transmitted helminths, and we don't have a leash that it is in the clinic yet. I think that, they're working towards moving it into the clinic, and onco, of course, so a little trick.
And this is just from me. I was wondering, the Valley of Death, where the term come from?
So I think that the term actually came out from scientists and researchers within the NIH. And I can leave it, if you send me your email, or I can email you, I can send you a reference that it's in, I think it's Nature Translational Medicine, I don't remember what. And they actually explain that the Valley of Death is really referred to the fact that at each stage of development you have a lot of high risks of failure. So it could be a failure, of course, in showing the preclinical concept of feasibility, but most likely where things fail are either in the production scheme, because you don't have a good production that leads to eventually good manufacturing. It fails in the fact that you can maintain a good stability profile, but more importantly, usually where it fails is in the safety aspects when you enter into the human studies. So the fact that you see, there's a slide that pharmaceutical companies use all the time where you can start with hundreds and hundreds of leads or targets that you want to try to evaluate, and the likelihood that one reaches all the way to development, it's very hard. So so you have this system where things basically fall off the path because they fail in one area or the other. The moment you pass safety, usually you feel more confident that you may have a little bit better chance of getting to the end. That said, in the types of vaccines we work on, which are these neglected diseases, there is a lot of unknowns still yet of what we define as efficacy. So we don't have correlates of protection. We don't know how humans will really react, because all our work is in animal models. So sometimes that translation from animal to human is a big black box, right? So that's what we call the Valley of Death.
I have a question for Maya Elena.
Yeah, go ahead.
Yeah, I can go. Maya, if these vaccines against parasites are supposed to limit transmission of the parasites, they can be considered, considering the countries where we have to use this vaccine, they can be considered as a soap, very cheap soap that you use to clean inside the body. So they must be very cheap, very affordable, and very safe. So what are the technologies used to develop such vaccines against such complicated
So you're absolutely right. So we don't only have the challenge of ensuring that you select good candidates, but it's the fact that you have to create a pathway that the production as well as the access to them would be, probably less than even $1, right? So they have to be freely available. So the way that we're approaching it, so it's a different level. So in the area of manufacturing, which is let's call it a cost of goods, we use very well-known, very well used and understood platforms. So for example, we don't get involved into very high sophisticated technologies that have a lot of proprietary restrictions. So we use things that are already in the open domain, like recombinant protein productions in platforms of yeast or E. coli that are widely used and they're freely available and there's no real restrictions of use. When we look at, for example, some of the resins that we use for, let's say, in the purification schemes, we tend to use ones that are very cheap and that they're also readily available, even here or even in overseas, where, eventually, if a manufacturer, in India has to have access to it, it has to be affordable and accessible also for them. Using equipment and infrastructure that are easily cleaned and that has not a lot of onerous processes of validation. That's another process. So for that, as an example, we actually engaged the manufacturers solely in the nonprofit sector. So we work with Brazilian manufacturers. We are now in discussions with India manufacturers. Here in the U.S., we generally work with nonprofit entities, which happens to be in the U.S. government, so, in the Army. And then in the area of delivery, when you plan how would you even distribute such a vaccine, there's by no way you are going to be able to, for instance, set, a standalone delivery system for just the hookworm vaccine. You have to integrate it in other delivery platforms. So other vaccination campaigns, mass deworming programs. So if you already have a deworming program and you're targeting the same population, then you just piggyback on already, established interventions in the countries. Like, the question you were asking, if there's already a water sanitation control program, you will basically add on a vaccination campaign to that. So so when we plan what we call our global access, there are a series of criteria that we have to make sure that we address to ensure that cost of goods are low, distribution are low, industrial manufacturing is low, and also, of course, access to the populations is low. All, at the end of the day, have to be below $1.
Okay, great.
Does it make sense? Easy said, more difficult to do. But
Exactly.
Okay. Thank you, Dr. Bottasi, for joining us. And I think we have a great session again, and this is our last session. Fred, would you like to have a closing statement for the MOOC Vaccinology?
Well,
Yes.
thank you. I certainly appreciate the opportunity. I hope it was valuable to have the lecturers as well as the students hear a little bit out of a different perspective of how can we, develop new strategies, new interventions for diseases that certainly impact, a huge population of very underserved groups, poor kids, poor populations. So look forward to more participation.
Okay, great.
Thank you very much.
Thank you.
Elena. Thanks a lot. So lastly, for the students, well, this is our last session, and this new MOOC lasts for a month and a half, something like that. So we'll terminate next week.
Yeah.
You have the final exam. I think there will be some, you've been warned on that, there will be some technical problems on the platform, on the FUN platform.
Yes, on November 8th to November 11th, they have a maintenance, but everyone can finish their exam until November 15th.
Yes, exactly. Don't get worried if you don't have finished. Maybe we might be. It might be possible to reopen the platform at that moment. So the next year, the course will be given next time similar course. We will probably manage to modify some things, but the course will continue next year. So don't miss continue following all the information on the networks, all the information sent by GB that I thank very much by this occasion for having make all this management of the information on the internet, Facebook, Google+,
yes.
Twitter, etc. So you can find all the information on that MOOC for the next year. And this year in March will be the face-to-face course of vaccinology at Institut Pasteur in Paris. Will be in March, and you will be able to meet with all the lecturers that you've seen the video during this this MOOC. So thank to all the participants of the MOOC. Thank to the lecturer. Thank you, Maria-Elena, for being with us on this last session. And thank you very much, GB, for your work on that.
Thank you.
Thank you.
Thank you. Thank you.
Bye, everyone.
Bye.
Bye, everyone.
Bye-bye.